Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, let me welcome a very renowned doctor, Dr. Vicky Jain. Sir is MBBS, MS General Surgery, MCH, Plastic and Reconstructive Surgery, consultant at the Aesthetic Clinic, Mumbai, visiting consultant and plastic surgeon at St. Elizabeth Hospital, Masana Hospital, Spectra Hospital, Mumbai. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is a bulging concern, case-based insight into AV fistula pseudoaneurysm. Now, without any further delay, let me welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Hello friends, I'm Dr. Vicky Jain, plastic and cosmetic surgeon, practice in Mumbai, as told by Sriyan. So today I'll be talking about swelling which is rare but can be daunting for life also, can cause issue, a patient can die immediately if it bursts. It is a pseudoaneurysm. So this is a case study of a patient, uh, a old female who had dialysis done via AV fistula, and because of a recurrent pricks, she developed a pseudoaneurysm. Now she got a renal transplant done, and she wanted the fistula to be closed. But when she came to me, she had this kind of a swelling, which is proximal to the AV fistula site. So a case of CRF, chronic renal failure with renal transplant done, at present off dialysis, the patient was on dialysis, came with a complaint of large swelling over the upper arm due to AV fistula. There was a thrill and was pulsatile also. Doppler suggested of a pseudoaneurysm, large, proximal to the AV fistula in the vein due to repeated trauma due to previous dialysis. The surgery was done under brachial plexus block and under tourniquet to avoid unnecessary bleeding. Surgical procedure was excision of the pseudoaneurysm and anastomosis of the brachial artery. Surgery time was to 90 minutes. Patient intraoperative radial pulsations were present once the brachial artery was repaired. Patient in 14 days follow-up was doing fine till the suture removal was done. So right now I will be showing you the surgical process, how the surgery was done, and will help you. I'll explain you the steps also, how it was done, and I think yeah. So this was a case of a pseudoaneurysm, which is there on table. So what we did is initially we had print and draped, and with butering this thing, we took a incision at the elbow crease, making sure that we go deep and deep and deep. And once we went deep, we had to dissect. It was a very bloody field, so that's why we had applied a tourniquet. We went slowly, and we dissected the vein. So you can see the thin vein which is being dissected slowly. You have to make sure that there's no injury to the vein. And once this was done, we can see the vein going horizontally. So the white part, which is just above the forceps, is the vein. And because of some subtle injury, there was an injury to the vein AV fistula graft, and there was a collected blood in the pseudoaneurysm. So we drained it out to decrease the swelling. So you can see how it is being drained out from the pseudoaneurysm. And once everything was done, we slowly tried to separate the artery from the vein. And what we could do is we could find the brachial artery, but it was very difficult because of the adhesions. And we dissected the brachial artery slowly. And this is the white thing which we are clamping, is the brachial artery. As you can see, it's a difficult surgery, uh, and we have clamped the brachial artery. And once we find the lower end, also the distal end, we have clamped the lower end also with the vascular clamps. And once we have recognized the proximal and the distal end, we have done is we have cut the AV fistula site, and is the vein graft, vein which is being cut, and this is the brachial distal part, and this is the brachial proximal part, as we see, and we have applied vascular plants, which will make sure that everything is fine. So slowly we started dissecting the vein proximally, and we had to take a cut over the pseudoaneurysm. This was a cut. We have to be cautious because sometimes these cuts can cause blackening of the skin also, because abundant vascular supply which is gone once we remove the pseudoaneurysm. And slowly we remove the pseudoaneurysm from the skin, separating it from the skin and the surrounding tissues. So it's a difficult surgery. It looks simple, but the fear of bleeding is way too much, and it was huge. As I can tell you, a hydrocele test is maybe it was 8 by 8 centimeters, huge, quite huge pseudoaneurysm, and this is how we separated. And since this was a pseudoaneurysm, there was a vein in continuation. So the proximal vein to the artery was separated, and we had to make sure that we ligate the proximal part also, the distal part to the AV fistula. So what we had done is we separated entirely. We ligated the vein. Just as you can see, there's a vein which is proximal to the pseudoaneurysm, and this is what we're getting. So you can see how huge it is. My entire fist is holding the pseudoaneurysm, and we have already ligated the vein. We have clamped the vein, and we will ligate it once everything stops. Ligation was done, and this is how huge the pseudoaneurysm was, and we could see the clot. So we had the chance of opening it up, and you can see how thick is the walls. This is how thick the wall was. And what is pseudoaneurysm? Is not it's a it's called pseudo because uh, all the walls are not involved. Then was the difficult part to repair the brachial artery. So we had a fear of that vascularity might be a problem, but we didn't have. Once the tourniquet was down, we had to stop the bleedings, the bleeders, and everything. And then we started the microvascular repair. As you can see, this is the proximal part of the brachial artery. We let it bleed first, clear up the clots, and slowly, with 7-0 proline, the suturing was done. It's a microvascular repair. We took approximately 21 to 30 sutures around the brachial artery, and which make sure that everything is fine. So intra of the needle, pulsation was also there. And once we were done with the entire vascular repair, we let it open and we let the bleeding come through. And then once the clamps were released, we started cutting the excess skin because there was obvious excess skin over the swelling which we removed. And once the bleeding was stopped, we had a good vascularity. The suturing was done. So it was a done safe procedure. Didn't have any problem. The brachial artery is pulsatile, as you can see. And I will stop this. So brachial artery was pulsatile, as you can see. Now we'll be discussing about the how this what is pseudoaneurysm. So a pseudoaneurysm is a localized blood collection outside the vessel wall due to a disruption in the vessel wall. Unlike true aneurysm, it lacks all three vessel walls, intima, media, and adventitia. Can occur in AV fistulas due to repeated needle punctures, trauma, and infection. What are the causes? Repeated cannulation in dialysis patient. Since we had this case, infection as access site, vascular trauma or injury, poor needle technique, inadequate fistula maturation, and arterial hypertension leading to vessel wall stress. Pulsatile mass, what are the findings? We have a pulsatile mass over the fistula site, pain and tenderness at the site of the pseudoaneurysm. Bruit or thrill might be present, the ideally present. Skin thinning, which can cause ulceration over the aneurysm. Sign of infection is redness, warmth, or discharge. Physical examination, palpation of a pulsatile mass. Doctor confirm flow pattern and assess thrombosis risk. CT angiography is normally not done in a CRF patient, but can be done in a patient who has a in present sonorism, just accidental finding, and blood test, infection markers, hemoglobin, and everything has to be checked for. Complication, it can rupture and hemorrhage, life-threatening emergencies. There can be thrombosis, which can cause AV fistula failure. There can be infection, and infected fluorisms can cause issues. They can have fever, and it can be skin ulceration and erosions, and high ischemia because seal syndrome. What is high ischemia? Seal seal syndrome? Because the blood flow in the fistula sites goes so much that the hand, once the blood flow from the fistula site is going so much, so the flow towards your hand is very less, which can cause seal syndrome. What is the treatment? Conservative management. Small acyclovir pseudoaneurysm being monitored. Compression therapy is always used initially in dialysis patient. Sometimes if the fistula is not working, but the pseudoaneurysm is there, we can use the thrombin injection. Surgical repair for large symptomatic infected pseudoaneurysm, yes, which we have done. Endovascular repair, stent placement in selected cases, and fistula dilation is there. So conclusion, pseudoaneurysms in AV fistula patients are a serious complication that require early detection and management. Regular monitoring and good cannulation practice are key to prevention. Treatment options depends on the size, symptoms, and associated complications. Thank you. Yes, sir.
Thank you so much, sir, for this wonderful presentation. We do have some question if you like to take that up.
Yeah.
So, sir, the first question is, how do we assess the risk of rupture in a pseudoaneurysm, and what are the red flag symptoms?
I cannot get you. I suppose your voice is cracking. Can you
Okay, let me just repeat it, sir. The question was, how do we
can you type
assess
it?
the risk of rupture in pseudoaneurysm, and what are the red flag symptoms?
So basically, it's a clinical diagnosis in the pseudoaneurysm that we find it out. There's an obvious pulsatile swelling happening somewhere near a vascular malformation, and if we think the skin thinning of the skin, obvious bluish discoloration of the skin, and can cause issues. So pseudoaneurysm better to be treated earlier than before it becoming an emergency.
So next up, what are the common etiological factors leading to pseudoaneurysm formation in AV fistula?
So basically, the longer the fistula site is, AV fistula is patent, the more the chances of formation of AV, pseudoaneurysms. Poor needling technique, poor again and again trauma happening to a single place can cause all these things. So sometimes it's inevitable, but I would suggest good dialysis technician will detect it early and avoid it, I suppose.
Thank you. So there's one last question. What role does infection play in pseudoaneurysm formation, and how should infectious pseudoaneurysm be managed?
So basically, in infections, small micro infections by the needle with the skin infection going on can cause issues. So infection doesn't play, but more of the trauma plays a effect in the development of pseudoaneurysm. But infection is uh, uh, what I say is can be a reason, small reason for a pseudoaneurysm going bad.
Thank you so much, sir, for answering all our questions. That's all from our audience. Before concluding, any take-home message?
So pseudoaneurysm are common. The better the earlier we detect it, and anything is there, just go to a surgeon or vascular surgeon or plastic surgeon who is able to help you. Because this can be life threatening. The patient can die on spot in 5 minutes if it bursts, if it ruptures.
I think sir has lost connection with us. Let me check. Just wait, please. So I will request our audience to stay with us as sir is facing some technical issue. He will be joining shortly. Thank you. Firstly, I would like to apologize to every audience, everyone who have joined, because I think sir couldn't join because of some technical issue. So now I would like to conclude. Thank you so much to everyone who has joined our platform for this wonderful session, and thank you for being patient. Thank you.